Hello, welcome to Cardiovascular Lecture 15. In this lesson, we're going to cover the pulmonary and cutaneous circulations in two short videos. Part 1 will consider the special features of the pulmonary circulation. And here are your learning outcomes for this lesson. The pulmonary circulation is designed to bring blood and air into very close proximity. It is designed to function as a gas exchange interface. Blood is brought to within 1 micrometer of little air-filled sacs called alveoli. Clusters of these alveoli branch off of the small airways like grapes on a stalk, and this is where blood releases its excess carbon dioxide to the inspired air, and oxygen is taken up from the air into the blood. Note that the pulmonary artery brings deoxygenated blood, colored blue, and blood leaving the capillaries is loaded with oxygen, colored red. To function as an efficient gas exchange interface, the pulmonary circulation has several special features. First, it has a very high density of capillaries. And second, the space between the blood and the air is extremely narrow. The only barriers between blood and the air inside the alveolus is the extremely thin capillary endothelium, the basement membrane, and the equally thin alveolar epithelium, and this very thin layer of surfactant, which is a mixture of lipoproteins that reduce surface tension, and this helps the alveolus remain expanded. Notice that there is virtually no interstitial space. The lung is normally kept relatively dry. Normally, the starting forces along the capillary greatly favor absorption, keeping the interstitial space narrow. The pulmonary capillaries are beautifully optimized for diffusive exchange of gases. Together, all of the pulmonary capillaries hold about 75 mL of blood. So the entire volume of blood in the pulmonary capillary is replaced with each stroke volume of the right ventricle. With 300 million alveoli in the lungs, the interface for gas exchange is enormous. Oxygen and CO2 are exchanged across the capillary by simple diffusion. And this diffusive exchange is made extraordinarily efficient by several specialized features of the air-blood interface to optimize every parameter in Fick's law of diffusion. Both oxygen and CO2 are very small hydrophobic molecules that penetrate the cell membrane very rapidly, so the diffusion coefficient is very high. The area available for diffusion is enormous. It's about the size of a doubles tennis court. And the driving force for oxygen and CO2 exchange is maintained by continuous capillary flow. And finally, the diffusion distance, x, is extremely thin, just 1 micrometer thick. As you might expect, the transit time for blood to move through the pulmonary capillary varies with cardiac output. At rest, it takes a red cell about 1 second to traverse the pulmonary capillary. During exercise, when both stroke volume and heart rate are increased, the transit time is decreased to about 0.3 seconds. And in healthy individuals, this is sufficient for complete blood alveolar gas equilibration. And oxygen uptake is normally complete within about 0.25 seconds. Its transfer is not diffusion limited, but rather perfusion limited, and the only way to transfer more oxygen would be to increase blood flow. Let's chart the path of oxygen from the alveolar air to the red blood cell. Oxygen first diffuses across the very thin film of surfactant proteolipid. It then crosses the 2 membranes of the alveolar epithelium in series. It then traverses the basal lamina, and then crosses the 2 cell membranes of the capillary endothelium. Oxygen then diffuses through the blood plasma to cross the red blood cell membrane, where it binds to hemoglobin inside the cell. So to summarize, oxygen travels through a thin film of surfactant, 5 plasma membranes, 2 cytoplasms, a fused basal lamina, and the blood plasma. And this entire journey occurs in less than 200 milliseconds. This rapid diffusion of oxygen and CO2 rely on the proximity of the air in the alveolus to the blood plasma. And this depends on the extremely close arrangement of the alveolar epithelium and endothelium. The lung tissues must remain very compact and thin. What would happen if excess fluid filtered out of the blood plasma and accumulated within the interstitial spaces of the lung? Edema in the lung is prevented by one very special feature of the pulmonary circulation, and that is, it is a low-pressure circuit. And this is because the pulmonary circulation offers very little resistance to blood flow. The left ventricle must pump blood to every organ in the body. The right heart pumps the same volume of blood to just one organ, the lungs. And because the pulmonary vessels normally offer very little resistance, it is a low pressure system. Pressures in the pulmonary circuit are about 1/5 of those in the systemic circulation. Instead of aortic pressures of 120/80, we typically see pulmonary artery pressures of 25/8. And by the time the blood reaches the pulmonary capillaries, the pressure is reduced to only about 7 torr. This compares to a much higher pressure, 25 to 50, in all other capillaries of the body. And this has an important consequence. Because the pulmonary capillaries are normally subjected to a very low hydrostatic pressure, the driving force for transcapillary filtration is very weak. There is normally a large pressure imbalance favoring fluid absorption along the entire length of the pulmonary capillary. This constant tendency for fluid absorption ensures that the lung tissue normally stays dry and compact. This is essential for efficient gas exchange. This means that a large rise in capillary hydrostatic pressure, at least 17 millimeters mercury, is required before pulmonary edema can occur. This is called the pulmonary edema safety factor. Imagine what would happen in left heart failure. When the left ventricle is weakened by disease, it struggles to move blood out of the lungs, to decongest the lungs. The failing left ventricle can only pump an adequate stroke volume and clear the lungs of blood if the filling pressure is elevated, say to 25 torr. At that elevated filling pressure, the ventricular myocardium can take advantage of the Frank-Starling length-tension relationship to generate more tension during systole. Because there are no valves between the left atrium and the pulmonary veins, this elevated pressure is transmitted back to the pulmonary vasculature. The force of filtration, hydrostatic pressure, now exceeds the force of absorption, oncotic pressure, and net filtration will occur along the pulmonary capillary. The pulmonary edema safety factor is exceeded, and net filtration will cause pulmonary edema. This is congestive heart failure. The edema can be heard with the stethoscope as wet, gurgly sounds in the lungs. These sounds are called ralls, and this edema has several deleterious consequences. Quick reminder, we can model congestive heart failure graphically on a PV loop. Here is a normal PV loop with a healthy ventricular function curve. Here in red, we superimpose a failing heart with lower inotropy, contractility. This heart is clearly unable to generate a stroke volume to maintain arterial pressure, to satisfy the baroreceptors, and to perfuse the critical organs of the body, like the brain and heart itself. On the next beat, as the continuing venous return adds to this high residual volume, the heart will operate at a higher filling pressure, taking advantage of the Frank-Starling length-tension relationship to develop a higher stroke volume that can maintain an arterial perfusion pressure to meet the demands of the critical organs. But the operation of the failing left ventricle at higher filling volumes and pressure has several negative consequences. As we have just seen, the elevated end diastolic pressures are transmitted back to the pulmonary capillaries, and the patient will develop pulmonary edema. Another important difference between the pulmonary and the systemic arteries is that the pulmonary arteries have much greater capacitance. They have very thin walls and they distend easily. Because of this, and because the pressures are low, gravity has a major effect on the distribution of blood flow through various regions of the lung when we stand up. When we stand upright, arterial pressures in the center of the lung, at the level of the heart, are about 15 torr, as shown in this graph. But owing to the effect of gravity, the pressure in the base of the lungs rises to about 21 torr. And this extra pressure causes these high capacitance pulmonary vessels to distend, lowering their resistance further and increasing flow through the base. At the apex of the lung, gravity subtracts pressure from the pulmonary vessels, and pressure falls to only about 3 torr. And as a consequence, these vessels collapse during diastole. These effects of gravity explain, in part, why blood flow through the base of the lungs is about 10 times that through the apex of the lung when we stand upright. Fortunately, as you will learn later in Block 2, the lungs are designed to deliver more air to their base. The base is ventilated by more airways than the apex. And this allows for a better matching of ventilation with perfusion along the vertical gradient. In other words, to bring more air in close proximity to where blood perfusion is maximal. The lung has another amazing mechanism that helps match regional ventilation and regional perfusion. We've learned that when tissues become ischemic, starved of blood flow, or hypoxic, starved of oxygen, the arterioles dilate to augment local blood flow. This is the local metabolic vasodilator theory. This mechanism works just the opposite, though, in the lung. Hypoxia causes local vasoconstriction in the lung. Makes sense. The purpose of this special mechanism in the lung vasculature is to match regional blood flow to local alveolar ventilation. You want the blood flow shunted away from the underventilated areas of the lung. You don't want to waste blood flow to an area of the lung which lacks oxygen due to poor ventilation. Let's look at an example. Here we see deoxygenated blood, 70% saturation, perfusing two well-ventilated alveoli. As the blood passes by these well-ventilated alveoli, it loads up with oxygen to near saturation, 98%. This is the normal situation in the lung. Here we see deoxygenated blood passing by one well-ventilated alveoli and a poorly ventilated alveoli. Ventilation of this alveolus may be impaired by airway inflammation or mucus obstruction. In response to the local hypoxia surrounding this poorly ventilated alveolus, the arteriole will vasoconstrict and shunt away blood flow from this area. You will hear much more about ventilation perfusion matching, VQ matching, from Dr. Heinrich. What would happen if the entire lung were to become poorly ventilated? Suppose you attempted to climb Mount Everest. On the summit of Everest, at 29,000 feet, the oxygen tension is only 1/3 that at sea level. So every breath of air that you inspired at that altitude will have only 1/3 normal oxygen. This can cause widespread pulmonary hypoxic vasoconstriction, converting the pulmonary circulation from a low resistance to a high resistance circuit, resulting in pulmonary hypertension. Pulmonary hypertension, in turn, will promote fluid filtration out of the capillary into the interstitial spaces to cause pulmonary edema, and this will widen the diffusion distances and impair gas exchange. Because even less inspired oxygen diffuses into the lung tissues, there is worsening pulmonary hypoxic vasoconstriction. This sends the individual into a positive feedback loop, a worsening downward spiral. This individual would show signs of dyspnea, exhaustion, rapid pulse and respiration rate. Remember those arterial chemoreceptors. Coughing with pulmonary ralls due to pulmonary edema. Fever and cyanosis, blue discoloration of the mucous membranes and skin due to deoxygenation of the blood. Any downward spiral driven by a positive feedback loop can cause death quickly. How could you treat patients with high-altitude pulmonary edema, or HAPE? Immediate descent, supplemental oxygen. Experienced climbers avoid HAPE by rigorous and careful acclimatization. Over the course of about a month, they make repeated short trips from base camp to increasingly higher levels on the mountain, with immediate return before their final ascent. Pulmonary hypoxia can also occur in patients with impaired lung ventilation, patients with chronic obstructive pulmonary disease, COPD, which is a combination of emphysema and chronic bronchitis. In all of these cases, some regions of the lung are poorly ventilated, causing reflex vasoconstriction. And if this involves large areas of the lung, it can produce pulmonary hypertension. This is a dangerous condition because if it persists, it can lead to right heart failure. Recall that the right heart is just not accustomed to or adapted for high pressure afterload. And as we have seen, pulmonary hypertension can lead to pulmonary edema. And this will impair gas exchange in those areas of the lung that remain functional. The same situation could result from mitral valve stenosis. Just a few words about pulmonary hypertension. This is a very serious disease that can have many etiologies. It can result from a variety of lung diseases that impair alveolar ventilation, obstructive lung diseases like COPD, or restrictive lung diseases that impair the expansion of the lungs during inhalation. All of these can trigger hypoxic pulmonary vasoconstriction. Pulmonary hypertension can also result from blood clots in the pulmonary vasculature. This is called thromboembolic pulmonary hypertension. When a thrombus occludes a pulmonary artery, choking off blood flow to a region of the lung and increase pulmonary vascular resistance. And since the pulmonary circulation must receive the entire cardiac output, any increase in pulmonary resistance will result in pulmonary hypertension. Yet another cause of pulmonary hypertension is left heart failure. The failing left ventricle must operate at elevated filling volumes and pressures to take advantage of the Frank-Starling length-tension relationship. But these elevated pressures can transmit back to the pulmonary vasculature and cause pulmonary hypertension. Let's take one more look at the Starling forces across the pulmonary capillary. Recall that the low hydrostatic pressure in the pulmonary capillaries in the face of a high oncotic pressure strongly favors fluid absorption from the interstitial tissues. If pulmonary capillary hydrostatic pressure should increase, net fluid can filter into the interstitium and expand its space. This situation is called interstitial pulmonary edema. Over time, that interstitial fluid can leak into the alveolus itself and further impair gas exchange. This secondary situation is called alveolar pulmonary edema, and in this worsening situation, gas exchange is severely impaired. Let's review the circumstances that can bring about pulmonary edema. First, pulmonary hypertension, more hydrostatic pressure favoring filtration. Second, anything that reduces the oxygenation of the alveolus or the tissues of the lungs will cause pulmonary hypoxic vasoconstriction. This can result from inspiration of air with low ambient oxygen tension, or from diseases which impede alveolar ventilation, or from inadequate respiration. As hypoxic regions of the lung vasoconstrict, the job of passing the cardiac output falls upon other regions of the lung. With greater blood flow and pressure, these other capillary beds will tend to develop edema. And as we've mentioned, left heart failure or mitral valve stenosis will transmit back higher pressures to the pulmonary vein, which can cause excess filtration. The pulmonary circulation acts as a filter for venous blood, and this makes it prone to embolism. An embolism occurs when a piece of debris is dislodged into the blood and flows downstream until it plugs a smaller vessel. The debris could be an air bubble or a clump of cells, but most often it is a clot of coagulated blood, and this is called a thrombus. A thrombus is composed of aggregated platelets in a mesh of fibrin protein. If a thrombus forms anywhere in the systemic venous system, it will flow to the right heart, and the next series of small vessels that it encounters will be somewhere in the pulmonary circulation, where it will plug up a small vessel. Depending on its size, small or large, the embolism can divert blood from small areas of the lung or large regions of the lung and cause extensive damage. This can make breathing difficult and cause pulmonary hypertension. This is a nice summary slide which lists the differences between the systemic circulation and the pulmonary circulation. Go through each one of these features and compare the systemic and the pulmonary circulations. See if it all makes sense. And that concludes part 1 of lecture 15. Take a short break. Come on back for part 2, a short video.